IL-6, TNF-alpha. Okay. All right, I don't know why that's. Anything else? So if you don't do anything, what happens? Joint destruction. Okay, and it happens early on. It can be a fairly aggressive disease, and so we have found that fairly aggressive treatment also does the trick. So if that comes up, let me know. Let's look on page 2. So what we're going to be looking at are the DMARDs. So these are disease-modifying agents of rheumatic diseases, and most people refer to them as DMARDs. They're categorized as non-biologic and biologic. Back in about 1980s, the treatment for rheumatoid arthritis was pretty much penicillamine and gold. We had aspirin. We used high-dose aspirin. So gold has an arresting or a anti-inflammatory effect, so we gave it usually injected. But we had very little way to arrest or stop joint damage. And so those pictures they showed you, and I've got one in your handout, of very deformed joints was very common. So we taught people a lot how to cope and how to deal with the disease instead of treating it. When Methotrexate came out, it was groundbreaking. And when the TNF-alphas came out, they were groundbreaking because at that point we could start to arrest the disease. So that made a huge, huge change in the way we looked at it. Now they use the concept of target to treat. Do they talk about that at all? Did anybody mention that? Okay. So let me go through a little bit more history. If you look at the biologics, and the difference between non-biologics and biologics is their target. So the non-biologics tend to affect lots of different parts of the immune response. So they may affect the cells, inflammatory cells, so they're much more global, and you'll see that in their side effects. So very global, the non-biologics. And there's quite a few of those. Methotrexate is the star in this group. The one right under it, leflunomide, is probably the second star. They're very, very effective. Sulfasalazine, hydroxychloroquine, these are old drugs. They are used for other reasons, but they've been brought in for their anti-inflammatory effects. Cyclosporin is a very immunosuppressant drug. We use it a lot when we're going to do transplants. So we can arrest the immune system very effectively. If you'll remember back to ulcerative colitis and Crohn's disease, we use this drug in very severe cases to induce remission. So they do the same thing. So just bring that concept forward in terms of inducing remission, and that is our first goal. Our main goal is to put the person into remission. Azathioprine, anything you remember about it? Okay. Another very strong immune modulator. We use it a lot especially if we're having to use steroids. So it's a steroid-sparing drug. That was another drug we used a lot with RA was steroids. But the problem was we caused as many problems as we solved, and we had to use it long term. Cyclophosphamide, another kind of like azathioprine, they're immune modulators. So is mycophenolate or Celsep. These drugs have broad applications through lots of different autoimmune or inflammatory diseases. You'll see them quite a bit. Problem with them is that they're very toxic in terms of infections and malignancies because of the degree to which they arrest the immune system. The non-TNF-alphas are just what they say. They affect other cytokines other than TNF-alpha. Then with the two newer ones, Benlysta is only for SLE. It's very targeted, and so are the Janus kinase inhibitors. That's an oral agent. It's also becoming more and more used in RA. because it has more data behind it. It's a newer agent, so not usually a go-to. Actemra, or that tocilizumab, is also another one of those that is up and coming in terms of treating RA. But newer agent, not as much data, and so it's more of a secondary. The problem with the TNF-alphas is that they are very, while they're very effective, they're also, their side effects are just as troublesome, and they're very costly. So they're usually not first choice, but they can be depending on the aggressiveness of the disease. So again, our target is remission, and that was not possible before the biologics and non-biologics came along. There were two big studies that came out. One of them was Ticora, and the other was the CAMERA study. And what they did is they looked at aggressive therapy with these drugs on RA versus conventional treatment. And what they found is that when you aggressively and early intervened and treated people with RA, you could arrest the joint damage and maintain it with low side effect profile and cost. And in the end, they felt it was cost effective because of the productivity you can keep the person in. You can keep them from having to go to drugs that have more side effects that cost more in the long run. So those studies introduce the concept of treat to target, or target to treat, either way. Okay. So the target here was remission. They also found it didn't really matter so much which drugs you used as long as your treatment got you to remission. So there's not a lot of protocol in terms of what do you treat, what's first, what's second, what's third. Most of it is based on experience and evidence. Okay? So we'll see that with methotrexate. It's been around a long time. It's got a lot of data behind it, lots of experience. We know what to expect, so you'll see it as the first-line drug. However, which one you go to from there depends a lot on the severity of the disease, the patient's other comorbidities, what they're willing to do, what their insurance will pay for. Okay? Most of the older drugs or some of the very effective drugs are used by injection. But now we've got drugs that are coming out that are oral, like Xeljanz. So people are going to want to prefer those orals over the injectable. Even though Humira is a very, very effective drug, people hate the injection because it's loud and it's uncomfortable. And even though it's effective and only every other week, people would probably prefer to take a pill. Okay, so the computer gave up. Okay, at break I'll see if I can get it to
Just shake the mouse.
Pardon?
Just shake the mouse.
I think that word cloud probably messed it up. Okay, here we go. So, which of the following toxicities is caused by hydroxychloroquine is related to cumulative dose? Sorry, I spelled that wrong. Okay, great, 100%. No, sorry. The big thing is retinol. Okay, if I didn't know, I'd go for liver too. Okay, so we've seen this drug before. The big thing to remember with Plaquenil is that is eye toxicity, and it is related to cumulative dose. Okay, it's 6 grams total. So however long it takes you to get there, after that you start to see lots of retinal changes. So it goes after it's toxic to the epithelial cells of the retina, can also destroy the macula, so big time changes in the eyeball. How long does it take a DMARD like methotrexate to produce a maximal response? We talked about this when we were in the UC and Crohn's, probably. The thing to take away here is it could take up to 6 months, but DMARDs take a long time to get maximum response. Months, weeks to months. Okay. So 6 months I put up there as so 3 months may not be wrong, but not everybody responds at 3 months. That's why we use bridge therapy, or with the nonsteroidals and the corticosteroids. Okay? So DMARDs, always remember, they are always slow. Okay? What supplement has to be taken? It's folic acid. Which of the following is a contraindication to the use of NSAIDs? Okay, renal insufficiency. Most of you got that. That's good. Which of the following is a selective COX-2 inhibitor? Celebrex. Okay. So we're going to see this because whenever you start using steroids and nonsteroidals together, your risk of ulcers in the stomach and in the gut go way up. So you have to protect the gut. So using a proton pump inhibitor is one way you can do it, and also, which is in the next one, or use a selective COX-2. Okay, so proton pump inhibitor, good, 97%. And then, I thought this was cool. I hadn't tried this one before, so let us see that. No. So it's interesting, whenever you all put in, it makes a word cloud. Kind of cool. So let's see what y'all put. Muscle tissue damage. Okay, that's true. So myopathies, people's muscles get weaker. Increased blood sugar, yes. Moon-like facies, because you get a redistribution of fat. Osteoporosis, very good. Weight gain. Skin thinning. So bruising. Stria can occur in the skin. Immunosuppression, hyperglycemia. Let's see if there's mood changes. Very good. Let's see what else we got. Bone degradation. Okay. Bone loss, fatigue, intolerance, cataract. What are you laughing at?
Someone put bone breakdown, question mark. Cataract.
I wish I could figure out how to make that bigger. But anyway, very good. Good job. I think what it did is the ones that you gave the most weight to, like weight and osteoporosis, they put those in the game. Okay, very good. Okay. All right. What is important for you to be able to do is to label something as a non-biologic or a biologic. Okay. You ought to know what the Janus kinase inhibitor is. Right. Well, who was Janus? Who's Janus?
From
Mythology.
No. I don't know.
Were you thinking Friends?
I was thinking Friends, the show.
Okay.
We're educated.
Got it. Okay. Next 2 pages. Yes. I'm going to curiosity. The God of the gates. What else is he known for?
Oh, he has the 2 heads.
Janus, the two-facing God, looking forward, looking backward. Janus. Yeah. Okay, so you learned something. Now, why they name that kinase, that I don't know. It must have a bi-directional way of going, I guess. Okay. So I'm assuming this is review. So here are, in rheumatoid arthritis, here are your major, all joints can be affected. The hands are very common. And so you'll see in the disease activity assessments, you'll see them a lot looked at. And they'll carry a high score. But you see all of the knees, hips, elbows, shoulders, all can be affected. So what happens is you get an inflammation of that synovial lining. And the autoimmune reaction to that causes a tissue formation called pannus. And that pannus is what destroys the cartilage and eventually allows bone-on-bone to occur. So did y'all talk about that?
No.
Sound familiar? Okay. All right, here's another picture of normal, and here's rheumatoid arthritis, and it starts to link then what cells and what, well, this one just does cells. So again, you've got that pannus formation, you've got that inflamed synovial membrane. That's why it's so painful for them and why they get stiff, why they lose the space, functionality over time. So major cell types, T cells, macrophages, neutrophils. So you get a recruitment of all those inflammatory cells. You've also got B cells that are going to produce antibodies against the antigen that the body is perceiving is present. T cells are in there that are going to start producing all those cytokines that are then going to destroy what the body is looking at as foreign. So here are the big ones. You all named them. So TNF alpha and interleukin 1, also interleukin 6, this one just doesn't have it. These are the major cytokines, and we'll see the drugs that are going to be targeting against those. And they just continue that cascade of inflammation and destruction that will keep going until we either do something about it or the person no longer is living. So it just is an ongoing reaction. I like this slide because it shows you the mast cells, the interacting with the immune complex, so that autoimmune process. And then you've got the production of those 3 cytokines, and it shows you then kind of what they each do. So some of them recruit more cells to come in. Some of them, and here's where you see that increase in C-reactive protein. They're going to measure that. It's going to be part of the disease activity assessment, is they'll look at it as one of the indicators of ongoing inflammation. So this one I think is good because this is where the drugs are going, and more of them are going to come out. You're going to see a whole lot more in this area in your career. So eventually, full joint destruction. So on a X-ray, this is what you see in normal joints, and then you see all those joint spaces are obliterated and no longer functional. So you have bone erosion and cartilage destruction and degradation, depending on how far along it is, and a synovial inflammation as well. So those are the hallmarks. So now what we can do is, if we early on, it is now recommended that at onset we start DMARDs, a DMARD, or a combination. And if we do that, we can stop that destruction, okay? We may not be able to keep it nice and pretty like that, but we can keep it close so that they don't lose functionality of those joints. When I was and you'll still see folks like this, when I was at your point, we had a clinic where the RA patients came, and this was very, very common to see in their hands, and you'll still see folks out like that, but we're trying to stop this. But you can even see in her early hands, you can already see joint enlargement and swelling. If you'll look at the names of those DMARDs, I've showed this to you before. This kind of shows you the different names. Remember, they relate to how much of it's human-like, right? So the first ones were all mouse, because that's where we grew it, and we didn't incorporate any of the human genome into it. Most of our drugs now that we're going to see here are Zumab and Umab. They're going to be humanized or human. We have one that's still used for infliximab, Remicade, that's still used in RA. But the problem is it being chimeric is that the body produces antibodies against it. So we can't use it by itself. We can use it with other biologics and to decrease that response. But most of these are going to then be human or humanized. Okay. So that means, the takeaway is, the body does not treat it like it's a foreign protein. Okay? So we don't produce antibodies. So if we produce antibodies against the drug, what happens to the drug? Neutralized. Doesn't work anymore. Doesn't work as well. Okay. All right. Questions, anything that you've heard now that you didn't hear, or not that you didn't hear, but is in conflict with what you've heard? Okay. All right. Can I turn the lights on? Yeah. All right. So let's look on page 5. You may have to, I don't have a watch and I don't have a clock. So someone, when we get, Kathleen, when we get close, like 1:45, will you just flag me? How did it get that late? Okay, we'll go to 11. When we get close to 11, let's do that. All right. Okay. So what's your role? There are PAs that deal with rheumatic diseases. Most of these patients are going to be seen by a rheumatologist. So there are PAs that specialize in that. Where I think you are going to encounter these the most is going to be in urgent care, ER, primary care. So I saw a lot of these folks in primary care because they had coagulation disorders or they had diabetes that developed from their drug or just because they were at risk. So knowing about them is important because you want to know what they are, and they produce lots of side effects. So they could show up in your ER with some devastating side effects. So we'll talk about those. And then you'll run across them in primary care to a greater extent, and so knowing what they are, what their side effects are, really important. And also, what do you do with preventative type care? Like when it's time for immunizations, what do you do? You've got an immunosuppressed person, can you give them injections? So just those kinds of things will be important. So that's how I see your role. General treatment principles, really important. Early recognition, so you may be the first one to see it and send them on to a rheumatologist. So early recognition, early treatment, that's the importance. Usually these people are going to be under a rheumatologist, and they should, because of the problem areas with the drugs and then the treatment of the disease. Early use of DMARDs within 3 months onset is what the guidelines recommend. The importance of tight control. So when we get to diabetes, we'll talk about tight control. Tight control means that when you assess their activity, you are shooting for a number on these assessment forms, and I'll show them to you. I've got a couple of them in the back. They are shooting for remission or low disease activity. If they're not achieving that, they will add drugs. They will go to combinations of things. Okay. So tight control has been, the goal of tight control translates into no destruction, decreased limitation, preserving joints. Okay, that's what tight control is going to mean. So tight control, usually when they talk about it, regardless of a disease, they are talking that if you do that, then the outcome is going to be very favorable. So it's usually something that's backed with evidence. You prevent complications, or you decrease or you delay the onset of a complication, or if the complication shows up, it's not as bad as it was before. Okay? That's the context of tight control. Anti-inflammatories, nonsteroidals, and glucocorticoids are only used in specific times. They're used early on. We'll go through this again. Early on, they work right away. You take a nonsteroidal, your headache goes away. Your shoulder ache goes away. Your pain goes away. So we're going to use those early on to get the person comfortable and under control. If we can't accomplish it with a nonsteroidal, then we'll use a glucocorticoid. And we might use them orally. We might inject the joints to try to get the person comfortable and arrest the inflammatory process while we wait for that DMARD to get Okay, you guys have got to stay with me. This is an important concept. I guarantee it will come up in your assessment, okay? So, know when to use those nonsteroidals and glucocorticoids. We'll go over it again. But they are only a bridge until the DMARDs are active. The other is that we might use them as a pulse therapy. Let's say they're on a DMARD, they're doing fine, they will have flares. And so we'll use them to treat a flare. So people talk about it as treating flare, pulse therapy, burst therapy. All of those terms are meaning that the disease activity has increased and we're going to treat it right now and then we're going to come off of it. Kind of like we did in asthma, remember? We had kids doing all right on asthma, they would have a flare, we treat it with a steroid, take the steroid off, leave them on their maintenance drugs. Okay, same concept. Treatment goal, really important, put a star by it, do not miss it on the test, okay? Treatment is low disease activity or ideally remission. Aggressive treatment, you could also term aggressive treatment as intensive treatment. So aggressive treatment is recommended to prevent joint damage, preserve function, improve long-term outcomes. So we talk about rheumatoid arthritis just affecting joints, but it affects all the organs of the body. Should talk about lupus, okay? So is lupus confined to the joints? No. What other organs does it hit? Kidney, lungs, brain. So if we can arrest the disease, we can also decrease those extra articular manifestations. I'm not going to talk about those, but they certainly occur with RA. Heart, lungs, also affected by RA. Skin, lots of different manifestations. Okay. Non-pharmacologic, so patient education is really important. Psychosocial interventions, you know, depending on what's getting in the way of therapy. What stressors are keeping them from prioritizing that treatment high. Rest, exercise, physical, occupational therapy, eat well, exercise accordingly. Interventions to reduce cardiovascular risk, because rheumatoid arthritis will increase their risk. Heart failure, heart disease. Smoking cessation, bad on the bones. We want to preserve their bones. So if they're not in a wheelchair at some point or have fractures. Immunizations to decrease infectious disease. So that's going to be important, is when do you do it? Some stuff we're going to do before we ever start them on a drug, but things will come up while they're on the drug, then what do we do? Pre-treatment evaluation. This one's important, put a star by it. I will ask you something on it. So before you start them, or before they are started, this is what takes place. One is they look at a CBC. Can you guess why? So these drugs are going to hit the bone marrow. So you want a baseline white blood cell, platelet, and red blood cell. Sometimes, depending on how low they fall, we'll take them off the drug. Methotrexate, influtamide, we will always be looking at those, and we'll take them off when they hit certain critical loads. Serum creatinine and liver, just put those together in your brain, because one is serum creatinine more because a lot of these drugs like methotrexate, you got to decrease the dose in renal insufficiency. If you don't, they'll get toxic and they'll get sick. Liver, a lot of these drugs cause liver problems. You'll see with quite a few of them, you're always going to be looking at aminotransferases. And what are those? ALT, AST. Okay, so we're going to be looking at those. We want baseline to compare. The SEV rate and the C-reactive protein, those are usually indicators of disease activity. So you'll see in some of these tools, they will be factored in. So you'll measure them. They'll be really high. You treat them, they should go pretty low. Okay. We want to screen for certain viruses. in particular in TB. So we're going to look, do you have hepatitis B? Do you have hepatitis C? Do you have latent TB? Why would we do that? You immune suppress them, these will manifest. If they're latent, then they'll come out, or they may come out. So those three things. And then if you think you're going to use hydroxychloroquine, if they have lupus, we're going to put them on hydroxychloroquine. It's our drug of choice. Okay? So we want a baseline. Those ought to all make sense to you. You ought to be able to remember those very easily because of the reasons. And you're far enough along now that you understand what happens if you mess up those organ systems or you immunosuppress somebody and what can happen from these other disease standpoint. Measuring disease activity. There are validated instruments. There's quite a few of them. I put 2 of them in the back. DAS is one that's used, DAS 28, the CDAI, and the SDAI. So let's look back at them. There are variables that are consistent with each of these. They're going to look at what joints are swollen, what joints are tender. They will ask the patient globally, how do you think you're doing? They'll have the provider put in there, how do you think the person's doing? Those get added in. Some of them will add a lab value like a SED rate or CRP, and some don't. Okay. So if you look back at the, let's see, page 20, page 22, the CDAI. This is considered one of the easiest ones to use clinically. It doesn't have all the variable, but it has enough. It is the offspring of the SDAI, which is behind it. So I've just printed them off so you can see it. Shows you how the score is formed. They look at the number of swollen joints, tender joints, patient's global assessment, provider global assessment. Comes up with a score. You see in the middle, there's an interpretation. Those scores, it tells you whether it's remission, low activity, moderate, severe. Okay? In the studies, that's what they look at. That's what they shoot. If you read a study about one of the drugs, they'll use one of these outcome assessments. It also shows you that so much of a drop in their score is significant, how significant that is. You'll see on this one, doesn't include ankles or feet, doesn't include the SED rate or the CRP. So if you look on the next page, it's a calculator, it's online, you can go online and look at it. And then I just included some notes about it and then references. On the SDAI, same thing, except what you see is you've got SED rate at the top. So it adds in other assessments. So it's a little bit better, but it takes longer to use. You have to wait until your lab comes back to do this. The other one you can do in the room when the patient's there. Okay. So I want you to be aware that there are these tools out there, and that's where the disease activity comes from. Because that will determine, do we do something today or not? If their disease activity has gone up, then we may add another DMARD, or we may do a burst therapy, or verify that they're taking their drug. Disease activity early on is assessed. You can do it monthly. Mostly when people get stable, it's every 3 months. So these folks are seen frequently. And because if you make a change, most of the response will be evident by 3 months, even though they may go ahead and continue to improve, that's another reason for that 3 month. If you're going to make a change, then you can assess its impact. Okay. Questions about that? 5 to, okay. Let's see. Okay, we're going to go through the next 2 pages, then we'll take a break. So in terms of choice of therapy, when to initiate therapy, definition of tight control, we've talked about some of those. How aggressive you are or how many drugs you use may depend on how severe the presentation is. If it's really severe, you're going to put a lot more drugs at them compared to somebody who's very, very mild. They also talk about poor prognosis factors. If you look down about five or six bullets. So poor prognostic factors can be lab, can be functionality. So they may look at how functionally impaired is the person. That could be a poor prognostic factor. If they have extra articular findings, so let's say there's something in the heart or the lungs or the kidneys. If they have a vasculitis, if they have, did you talk about rheumatic nodules? Okay, if they're present. So they're looking for more advanced or more extensive disease. They could be looking at an x-ray for bone erosions. You know, what shape are the joints in? Did you talk about those I can never say it. I always have to think about it. Anti-citrulline protein antibodies. Okay, those are a big thing in terms of disease activity, and they're more active in people who have more advanced disease or uncontrolled disease. Okay. So, level of activity, level of impairment, what are they complaining about, how bad is the pain, and then what are these other prognostic signs, which are usually telling you the disease is bad and you need to be aggressive. Patient preference, what are they willing to do? Are they willing to inject themselves? Are they willing to come back for appointments? Are they willing to come in and get lab? What will their insurance pay for? So those can play in. So combinations of therapies that are used. Usually early on you're going to use a nonsteroidal plus or minus a glucocorticoid plus a DMARD. It can be non-biologic or biologic. Usually we start with methotrexate. Could be a Janus kinase inhibitor, but that would be if you can't use the others. All should be started on a DMARD as soon as possible. That's about the 4th time I've said that. Don't any of you miss that on a test. Tight control strategies. Assess the disease frequently. So they're going to be going to the doctor every 3 months, at least. The regimen can be adjusted in that time frame every 3 to 6 months. So early on, they're going to adjust more until they get stable. Use NSAIDs and glucocorticoids to maintain control or attain control. Some to control until the DMARDs take effect. Under initial therapy, methotrexate is the DMARD of choice. It's been around a long time, has a lot of data behind it. It's it's relatively inexpensive compared to others. For those who don't take it, who won't take it once they've heard what they have to do or what the side effects are, then the options are usually other non-biologics. The flutamide or Arava is probably the one right after methotrexate. Very effective, it's an oral agent. Sulfasalazine, very old drug, has lots of anti-inflammatory properties, cheap, easier to take. Hydroxychloroquine can also be used. Those last two can be used in women who are contemplating pregnancy. If they have a low disease activity to start with, women in reproductive years, those are ones. But it's a limited group that you would do that in. The other would be to start a TNF-alpha. That would usually be like Enbrel or Humira. Add an NSAID or a glucocorticoid, systemic or intra-articular, for initial symptoms. Don't use them as sole therapy forever. And warn patients. They'll like them because they'll get quick relief. Okay, under C. Yeah.
Did you say the sulfasalazine for women trying to get pregnant? That
Yeah, it's not a teratogenic. Okay, so those two, remember, symptomatic relief, rapid relief, they improve inflammatory symptoms. We talked about the fact that they're there to, because of the DMARD's delay in relief, and using them for flaring disease. Let's see. Some patients will continue on them. People have very severe disease, they may not be able to get off a steroid, but your goal is always to get them off of daily steroids and nonsteroidals. Some patients will have a continued need for a steroid, but those are small. The reason we don't use them is they don't change disease progression. And with the steroids, it's the long-term side effects that are the big problem. There is data that has looked at steroids, and probably their biggest impact is in the first 6 months. But long-term, they are not as good as the biologics or the non-biologics, and they have the side effects are not acceptable. Page 7, the whole page is important. You should put that at the top. Whole page important. Know that they do not affect disease progression. That's why we don't use them long term. Remember your contraindications to NSAIDs. They've got a history of ulcer disease, if they're old, or if they're older, if they're renal insufficiency, cardiac disease. Remember we talked about with heart failure how they will precipitate heart failure. Be careful in your, when I say older patients, what's the age that I told you to start? 60, over 60. We use them until there's an adequate response. Now, it takes the nonsteroidals about 10 to 14 days for maximum effect, their effect. So they'll continue to get benefit up until about that 2 week. Then they'll sustain, but that's usually your maximum response is what you're going to see after 10 to 14 days of a steroid. Sorry, NSAID. Protect the gut, especially if you have to use a steroid and an NSAID together. Glucocorticoids rapidly will decrease inflammation. They're more effective than nonsteroidals in that regard, but they also have a heavier adverse profile. They can be injected into joints. So let's say you have one major, or 5 major joints that are causing trouble, and you don't want to use an oral agent. You could use the intra-articular. What dose to use? So there's different camps. There's one very good study that looked at starting high and titrating them down over a couple of months period. They started, 60 milligrams, and they titrated it down to 7.5, and then they maintained them on that dose out to 12 weeks. 12 weeks? Mm-hmm. There's some data even that says out to 6 months you still have very good effect on, at least if you're looking at x-rays. But beyond that, they don't recommend, chronic therapy. So it's not a push to do it, but it is saying a couple of things. One is that there are patients where that may be effective and where it may be very good to use that in their regimen. Other patients, small doses, 5 to 15 is good. It's maintenance. Usually the amount of adverse effects you'll have from that is low. 5 is considered pretty physiologic, so 10 to 15 above that until you've got the 3 to 6 months out with your DMARD is reasonable. So different ways to approach it. Am I going to test you over that? Probably not, but I want you to appreciate there are different ways. And it will change. It will change over your lifespan as they get more your professional lifespan. Okay, all right, let's take a 10-minute break. What time is it? 11:04.